All right, welcome back to the show, everybody. On today's episode, we have a very special guest, Tamara DeAngelis. Tamara, how you doing today, ma'am?
I'm doing great, Rich. How are you?
I'm doing awesome, thank you. Tamara, for those of us that don't know anything about you, can you please tell us a little bit about yourself and who you help, please?
Absolutely. I am a licensed clinical social worker in private practice, and I help women navigate the psychological and emotional aspects of the menopause transition, which is a pretty significant part of a woman's life. It's about a good 30% of our lives we spend in this time.
Wow, 30. Yeah, I mean, I'm gonna definitely ask you more questions about this, but before I get there, Tamara, I'd like to maybe ask you to kind of shed some light on these terms. I mean, I've heard perimenopause, menopause. Can you kind of help clarify what those words mean?
Absolutely. We tend to use the word menopause as an umbrella term. I think maybe a better umbrella term might be the menopause transition. It begins with perimenopause, which we can think of as a bookend to puberty. And that perimenopause can last from 4 to 10 years. It varies for different women. And during that time, she may have irregular cycles and lots of symptoms, which I'm sure we'll touch on as we go on today. And then after she's gone 12 months without a menstrual cycle, that marks menopause. And as soon as we hit menopause, right after that, we're in postmenopause. So menopause is a moment in time. It just marks that she's gone 12 months without a period, and then she will be in postmenopause for the rest of her life.
Got it. Got it. Yeah, that makes a lot of sense. And it's so interesting that menopause is only that moment in time. It's so interesting how they came up with that. Like, oh, this is your menopause after 1 year, and then
Yep.
now, you said menopause was 24 hours, or it's just
It's a moment in time.
okay.
It marks that she's gone for 12 months without a menstrual cycle, and it determines that she is now menopausal.
Got it. Okay.
And then she goes into
And
postmenopause.
post-menopause. Okay, that
Mhm.
makes sense. Um, yeah, that's interesting, and thank you for that, Tamara, because I didn't know that, and I'm also a clinician, and I'm like, yeah, these are really important things to understand. In your work, Tamara, what are some of the myths that kind of surround menopause, and maybe even what women are told about menopause?
Yeah, yeah. I think most of us arrive uninformed. Um, we may have heard about hot flashes. We may have heard about our cycle stopping. Um, but most of us are not well informed. And there's also the myth around hormone therapy being dangerous, which has been proven to not be the case. For most women, it is safe. And I think a lot of women often think that they have to be older before they experience symptoms. So, you know, women in perimenopause, for example, in their early 40s are experiencing symptoms, but they're not connecting the dots to menopause because maybe they think that's only for women over 50 or for older women. So I think that's probably a myth. And then also just reducing it to the couple of symptoms that most of us hear about, that there is a long list of symptoms associated with the menopause transition that often are part of the problem with being misdiagnosed or not being diagnosed in a timely way.
Wow, that's interesting. Do you find that I know you mentioned the word misdiagnosed. Do you find that some individuals are experiencing perimenopause? Did I get that right? Perimenopausal
Mhm,
symptoms, but they're
mhm.
actually being diagnosed for something else, and like they're actually not being accurately taken care of. Is that
Yeah, yeah, that happens frequently. I experienced that personally, where I was going to doctors for different symptoms that I had no idea that they were related to the menopause transition, and none of my care providers identified that for many years. And so that certainly happens with physical ailments or symptoms that are misdiagnosed, but also happens in the mental health field because people present with what looks like run-of-the-mill anxiety or what looks like depression. Um, and very often in both settings, women are dismissed. Their physical symptoms are dismissed by their healthcare providers who maybe tell them that they are stressed, that they just need to relax, or they just need to accept it because it's part of aging. And then, unfortunately, mental health professionals who are not really well versed in this life stage may go ahead and just treat the symptoms that they see presenting without understanding that there are underlying causes that really should be addressed.
Wow, yeah, that's so interesting, and, it's kind of wild to think that, um, healthcare providers are misdiagnosing people during a really important stage of development. Like you would think like, hey, people within this age range could be experiencing this. Maybe it's worth taking a look at it and assessing whether this is actually in play right now. And I hate that phrase, oh, it's part of aging, and I hate that. I went to the doctor a while ago and I had knee pain and the doc was like, oh, Rich, it's just part of aging. As you get older, you're going to start creaking and cracking. And I was like, no, and I ended up going to a sports, therapist, and it turns out my shoes were the wrong fit, and I was just like, so it's if that is if it happened to me with shoes in my knee, I could just imagine for, internal symptoms for somebody that's in that
Yeah,
menopausal transition. Yeah, that's gotta be,
yeah, yeah,
really wild, Tamara.
yeah, yeah.
Yeah. I was gonna ask, do you think where do you think that comes from? Like the I don't want to say lack of knowledge or information, but this like misdiagnosing of the menopausal transition. Is it training maybe or
I think it comes down to training and awareness. Unfortunately, women's health has always lagged behind, whether it's due to lack of funding or lack of interest. So, doctors, frankly, do not get the type of training that they should get related to menopause. Even obstetricians and gynecologists do not get a whole lot of training around menopause. They are well trained in puberty and pregnancy and postpartum, but not perimenopause. It's the third P that doesn't often get addressed. So that's what happens, and that is changing. It is changing, and it is coming from women who are speaking up and advocating for themselves, and female physicians as well. And now we have societies, and the Menopause Society is active in getting good information out there and trying to, they have a certification for physicians and allied health professionals to get proper training,
yeah, yeah.
because it's easy to miss it, because a woman shows up and she's got real physical complaints, and so that's what the doctors focus on.
Yeah, that's so interesting. Tamara, I'd like to go back to your own personal story. What was it like when, you know, you were as you were going through these misdiagnoses, you were seeking help from different providers, and then finally somebody was like, "Hey, you might want to like." What was that like, and what was the turnaround like after you got proper treatment?
Yeah, I went through probably 5 to 7 years of seeing specialists,
Wow.
having treatments, being on medications. I was otherwise a healthy person. I lived a fairly healthy lifestyle, and I've always been fairly fit and active. Um, and I slowly started having symptoms that were strange. I had all over body pain that I didn't understand. I had developed high blood pressure. I was taking two high blood pressure medications. I was taking medication for fibromyalgia. I was having injections in my knees because I had incredible knee pain. It was just a long list of physical complaints. And I had even gone to my gynecologist, and she never mentioned perimenopause to me. And eventually, a new doctor said, no, you're probably, in perimenopause and you would probably benefit from some hormones. And I began treatment. And it made such a difference for me in terms of my physical complaints that I had. And I was able to get off of all the medications that I was on. And that was so important to me because I began to think of myself, I began to wonder if I was going to be a sick person, if this was just getting old, and if this was going to be my new me. It was a really challenging time. So it challenged my identity about how I thought about myself. And that was hard. And even in therapy, I was in therapy at the time. The therapist was not menopause informed. Um, and it wasn't until I began to bring that information into therapy, what I was learning, that then I could sort of begin to connect the dots for me.
Wow, how quick was that turnaround, Tamara, from when you started getting the hormones to feeling better?
I think I started feeling better within a month or two, that
Wow.
a lot of my physical symptoms were relieved, at
Yeah.
least improved, for sure.
Yeah.
Yeah.
Wow. Yeah. And I could see how, as you're going through, or not you, but just an individual who's seeing different providers over and over the course of months and years, even, and then nothing's landing, nothing's helping. Yeah. I could see where an identity starts to shift. We start doubting ourselves and we start thinking, like, what's wrong with me? Like, nobody can help me. Like, nothing's working. These doctors, right? Like, we have so much trust in the system. And when it doesn't work, then we start thinking of ourselves a certain kind of way, and that could have a cascade of effects in and of itself, right?
Absolutely. I mean, and this is why I think that the work that I do is important, is because it impacts us on so many levels. It impacts, when we start having our identity impacted, that's going to impact our relationships. It impacts how we show up in our relationships. It impacts us in our careers. And all of this stuff is sort of showing up at a time where we are sitting at the intersection of aging and sort of new roles changing also. So, a woman may be at the height of her career and suddenly she's not sleeping at night, which is contributing to brain fog, which contributes to feelings of anxiousness and worry. And so now she doesn't know who she is at work, because she was this capable person climbing the ladder, ready for the next level, and suddenly she can't remember things. So that is one way it impacts. It impacts our relationships. Maybe she's feeling a lot of irritability. She's not sleeping. She's dealing with other symptoms, painful joints, other things like that. That will impact how she shows up in her relationship. She may not feel so generous. She may feel more irritable. So it is much more than the physical symptoms, although that is what gets a lot of attention, and that is also very real. I like to address some of the other symptoms as well.
Yeah, thank you for that, Tamara. Earlier, you mentioned something that really stood out to me, and that is the identity component of it. So let's say a individual goes to a provider who is trained to recognize menopausal transitions, and they are able to guide the patient and say, "Hey, yeah, like this is a process that you're in," and then they start that education. What shifts for that individual when they realize that they are in the menopausal transition? In terms of their identity, if anything at all.
Well, I think it's a process to arrive at the point where one begins to shift. And you're right. I think understanding where you might be in terms of the menopause transition, that information is helpful. And then we begin the work of sort of understanding, well, what does this transition present to me? Is this a time of loss? Is there some grieving related to no longer being able to have children? Is their grief and loss related to no longer having a regular monthly cycle? Is it an opportunity to sort of redefine ourselves and how we want to show up and be intentional about how we spend this last uh, 30% of our life? So it, as I mentioned earlier, it impacts our relationships and how we show up in our relationships. And that may be a reassessment of, do I want to continue to show up as the person who takes care of everything for everybody? Maybe I want to reassess that now. So I think it's complicated and it's layered and it's interesting. And I think that is the meaty part of the work, at least from where I sit when I'm working with women during the transition.
Yeah, that's so interesting. So many threads that we can pull on. But I want to kind of hone in on the relationships piece because as a marriage and family therapist, like when I hear marriage couples, like I'm like, um, um, what is it like for the families of the spouse who's going through the menopausal transition? And then also, what is it like for the partner? Do you? Yeah, let's just start there because I have a ton of questions for you on that, Tamara.
Well, I think it's often reduced to personality changes. The family or the spouse can experience this as a personality change, like suddenly she um, is more irritable or has less tolerance for carrying, maybe more of the load. Maybe she has begun to say no more. She also may appear withdrawn. She may be experiencing more fatigue and tired and not showing up in ways that she had previously shown up. So for the family, it's a tough adjustment because they're just seeing stuff on the surface. And if she cannot communicate what's going on because she doesn't have good information, it's a challenging time. And we see increased divorce rates around this age demographic. It's a tough time. So it's important. And if I can just kind of, maybe I'll leap ahead and talk about the importance of support from spouses and the importance of spouses being educated about this time period. And it's important because it gives the couple and or the family a framework to sort of operate within. So if we're all in agreement that a lot of the stuff that we're challenged with presently is related to the menopause transition, then we know how to operate together as a team in a united way. That okay, this is part of menopause. Let's how can we navigate this better? What adjustments can we make to support the couple and support her and the partner as well.
Yeah. Oh, that's so good because I could just imagine what it's like to um, experience kind of being not singled out, but everybody is looking at the mom or the wife or as like, oh, she's just being cranky.
Yeah,
We have a tendency to just kind of put a label on certain things, right? Like she is just blank. Insert whatever blank derogatory term there is in there. But as they're getting support and the family comes together or the couple or the relationship comes together, it's like a united front. I think that's what's really wonderful is that they are no longer feeling alone in this process. Now they have support, everybody's educated. It's like a collective united front against a natural transition. And I think that's such a wonderful thing. Do you work with couples in your practice, Tamara, and maybe even families? How does that work?
I do not. I only work with individuals, but I would certainly work with an individual family member who is living with somebody who's experiencing the menopause transition. I think that would be, appropriate, and I would be able to help them. But I primarily focus on supporting women
Got it.
during the transition. Yeah.
Got it. Got it. Yeah, that makes a lot of sense. I like to go back to the hormone therapy, if you don't mind. What happened with the research? Like, why did we stop? Like, can you kind of shed some more light on the treatment?
Yeah. Yeah. So in 2002, there was a big study, Women's Health Initiative, and it essentially led providers and women to believe that there was more risk involved with hormone therapy than we now know that there is. And, in the 1990s, it's estimated there was almost 40% of women who were in the age range to be on hormone replacement therapy were on hormone replacement therapy. That's a very, very high estimate. It was probably closer to 27. But at some point it was at about 40, and now it is estimated to be around 5%. So that's a pretty dramatic drop. We are now seeing a real movement. There's a lot of conversation around hormone replacement therapy. And of course, now there's a shortage of estrogen patches because we are having more and more prescriptions. I'm not sure why the pharmaceutical companies did not see this coming, because it has been a slow build, but that is where we are now. Hormone replacement therapy has been determined to be relatively safe for most women. Most women can take some form of hormone replacement therapy. If you are somebody who cannot use hormones, there are alternatives. And so that speaks to the importance of finding a provider who really is a menopause-informed provider who can discuss options with you. Because there are options. There are some SSRIs that help with hot flashes. There are other types of medications that are non-hormonal. So you're not, if you can't take it for whatever reason, there are other options out there.
Yeah. Wow. And it's so wild to think that one study just changed the course of treatment for everybody. And that was it until now. You know what I mean? Like, just like it seemed like a night and day difference as far as what happened with the prescription of the hormone treatment. Yeah, that's so interesting. Yeah, and I could only imagine what it was like for all the, what the cost was to women who could have benefited from having the hormone treatment back then in those days. Wow, that's so wild.
That's right. That's
Yeah.
right. Because we know how important estrogen is.
Mhm.
We know the impact of the decline of estrogen is throughout. I mean, it impacts our bones, it impacts our muscles, it impacts our cardiovascular health, which is why I ended up on 2 high blood pressure medications, because that was a result of a decrease in my estrogen. So it's important. It's important for healthy aging. This is not only about relieving symptoms, this is about healthy aging. So if we can have better bone health and we can decrease osteoporotic fractures, which when women break a hip, their mortality goes way up. If we can avoid those kinds of things, then women will live healthier lives. They will age in a healthier way. So it's important.
Yeah, and as you were saying that, Tamara, it just reminds me of testosterone for men. Like, as men age, right, testosterone just naturally kind of decreases, and that can lead to a whole cascade of effects. And yeah, and it's so interesting. I did not know that that estrogen was required for heart health and other areas of the body. And now that, as you're telling me that, it's like my mind's kind of blown. That it sounds like estrogen at a certain point could be critical, for healthy living.
Absolutely. And testosterone plays a role for women also. We also
Mm.
have a slow decline in our testosterone, and that might be another conversation, but that's an important hormone that we have also.
Yeah, that's so
Yes.
good. So I wonder, Tamara, what is kind of the danger or the risk of treating menopause or menopausal transition related distress as kind of run of the mill anxiety or just typical depression or stress? Like what's the risk of that?
Yeah. You know, look, the truth is, if somebody's in perimenopause, they're feeling anxious or they're having symptoms of depression, and they walk into a therapist's office and they treat it as run of the mill, they will probably get a certain degree of relief. The problem with it is that you are not getting to the underlying problems. So if we take anxiety as an example, um, there are other factors that are happening that are going to continue the cycle of anxiety if we don't address the other factors. So things like poor sleep. Poor sleep has an impact on our mood and our cognition. When we're not thinking clearly, we may, rely more heavily on flood thinking, be more susceptible to that kind of thinking where we're anxious and stressed. And then we're anxious and stressed and we're not sleeping. And it's a cycle that just kind of reinforces. So we have to have an understanding of what's happening so we know where to intervene. So in that circumstance, I would start with sleep. So I would start with, a sleep protocol and having her log and track her sleep and understanding, is she consuming alcohol? How is that impacting her sleep? Is she exercising? So it's like I'm starting with a sleep, even though she's presenting with the anxiety, where if I didn't have that understanding, I would start with the anxiety.
Yeah, yeah, that's so interesting. And as you're saying that, Tamara, it just makes me realize that it is probably a really prudent thing to do for clinicians to get training in the menopausal transition. Because as you're telling me that, now I'm going to just share something here. I never thought about this, and I remember seeing a client who was a police officer in her 40s, mid 40s, and this thought to me never occurred, And so not only is she a law enforcement officer dealing with first responder trauma, she could have also been going through this transition, and that intersection could have been a really challenging place to be in. And I was not aware of the menopausal transition. So now I'm just like thinking like, man, maybe I like, did I miss some things, and um, just out of not knowing, And so, what are your thoughts on clinicians getting training?
I think it should be mandatory. I think that if this is the demographic of people that you see, if you see children, you probably don't need to have menopause training. But if you're seeing midlife people, because even if you're seeing a partner of somebody who is experiencing the menopause transition, that's information that's important to have. But I think a real fundamentals kind of 2 CEUs required, um, to just understand some things to look for, to know when to refer if this is not your area, and or if you want to make it your area, great, because we've got a whole lot of people in this stage of life that are misunderstood and mistreated or misdiagnosed, I should say.
Yeah, yeah, it's so interesting because me being a, a prior a veteran, I love working with veterans, first responders, and so as this client was coming in, I was like, yeah, perfect, like I'd love to help, and didn't acknowledge that this is also a very real possibility, and so definitely could have. Now looking back on in hindsight, I'm like, man, I could have really talked with the team, the leadership team, and been like, hey, maybe and discuss this just
Mhm.
to make sure that this was on the radar. So lesson learned. Thank you for that, Tamara. I like to ask about kind of shift gears and talk about the relationship of the woman who's going through the menopausal transition and her partner, if they have a partner. Me as a marriage and family therapist, I understand that sex can be a very, very important part of a relationship. And I wonder, does can individuals who are going through the menopausal transition look forward to a healthy, fulfilling sex life afterwards? What does that look like?
Absolutely, 100%. And many women report better a better sex life. Um, And that has to do with sort of coming into your own and sort of feeling more confident in who you are and how you show up. But there are certainly symptoms that, physical symptoms that can present challenges in terms of physical intimacy. And, there's estrogen is important in the vagina. It's important in terms of sexual response. It's important in terms of lubrication. So, and there are treatments for that. There are very, very safe and effective treatments to help with sort of the physical part of it. But what happens is generally is that a woman will begin to experience sex as painful. Intercourse will become uncomfortable. So rather than talking about it, many women sort of withdraw. They may become embarrassed by it. They may feel insecure about it. They may assume there's nothing they can do about it. And the partner doesn't understand what's happening. The only thing the partner sees is her withdrawal. And so then the partner, as I'm sure you know, makes assumptions or, maybe feels hurt, takes it personally. So in terms of intimacy, sexual intimacy, it absolutely can be impacted. And there are lots of things that can be done to help so that it is not painful. There are other things other than penetration that can be very enjoyable and meaningful for couples in terms of intimacy. So that's part of the identity also. Changes, how do I want to show up sexually? What do I want? What feels good to me? What do I not want to do? All of those kinds of things. So I think it's a real opportunity for intimacy on different levels with couples. If couples can be open and talk about this and have good information as they sort of explore what's right for them, I think it can also enhance intimacy.
Yeah, thank you for that, Tamara. I really appreciate you shedding some light on that. If there is a woman that could understand one thing before entering perimenopause, what do you think it should be?
Yeah. So I I guess I would say hang on, get ready. Um, it is it is another version of puberty in terms of hormonal fluctuations and mood changes and um, maybe not understanding yourself the way you have known yourself up until this point. So it is a series of change, physical changes and psychological changes and emotional changes, much like puberty. So that's the way I would describe it. And I wish that we were better prepared for it.
Speaking of being prepared, Tamara, what is some good training that clinicians can kind of check out so that they could learn more about the menopausal transition?
Yeah, so I feel strongly about this. I feel strongly about getting good information into the hands of clinicians. And I spent a lot of time and energy looking for that information. I've been doing this for several years now. And when I first started, everything was um, directed towards doctors. Any kinds of trainings, they were for doctors or medical professionals. So that's where I started. And I started with the Menopause Society, which is the society in the United States. There is also the International Menopause Society. There's the British Menopause Society. All of the menopause societies um, I would highly recommend. And many of them are now doing trainings for allied health professionals. I know the Menopause Society in the United States has a brief CBT training. Anything that you can find from any of these societies that you can understand and digest, that is a good resource. I think you might have to be a member to access some of it, so you would have to look into that, but that's a good resource. Then I found a woman in the UK who I have been training with for about 2 years, who developed a menopause-informed third wave CBT framework, which has been very, very meaningful to me. And I continue to be engaged with her. And the name of the program, it's called EMBERS, EMBERS CBT. Her name is Simona Stokes. She's a psychologist in the UK, and her trainings are very comprehensive, evidence-based. She's constantly updating with new information. So that's certainly a good source. And then the final source is Perry Academy, which is in the United States. And they have a fantastic training where you can get a certification in perimenopause through them as an allied health professional. And I actually can provide your listeners with a link, with a discount link for that training. And what I love about that training is each module is taught by a different professional. So like a cardiologist, a sex therapist, a pelvic floor specialist, all kinds of specialties. And they teach the module from their perspective, how they work with a woman in the menopause transition. What does a cardiologist take into account? What should somebody look for? And know when to refer to a cardiologist. So it's really very, very meaningful. And the language is at a professional level, and it's well done, but it's geared towards non-medical people.
Got it.
So it's a very, very good training. So I would say any of those would position you to at least understand the transition. Now, if none of that is an option for you, then I would say grab a book. I have book titles on my website, which I can leave with you, my website address. There are book titles and podcasts that I recommend as well. So the information is out there. It just is about being intentional about, going after. And again, you don't have to specialize in the area. You just need to know enough to know that this is probably could be impacting what's happening, what you're seeing.
Yeah. Thank you for sharing that information. And yeah, definitely, if you can leave those links with me, and I'll make sure to plug them in the show notes. And I think it's kind of prudent for clinicians to do this because if a woman is misdiagnosed or they're not diagnosed, the clinician can really serve as like a sort of second line of defense, you know what I mean, to make sure that we're capturing this. And maybe if we recognize some of the symptoms that are present in these trainings that they talk about, we could be like, oh, maybe you could go check out this doctor, or actually go back to your doctor and ask about this, because we don't want anybody to kind of slip through the cracks, so to speak, and not be properly treated, right? What are your thoughts on that?
Absolutely. And that's a big part of what I do with women is I help give them the language. We can role play conversations with your care providers because let's face it, we all know our healthcare system is not great. And when you are experiencing brain fog and you are feeling anxious and you're having all kinds of random symptoms that seem to be disconnected, and you go into your doctor's office and they have a waiting room full of people, and you just have a few minutes to try to explain what's going on, that can be challenging, and that can set us up to be sort of dismissed. So part of my work with women is I help them track their symptoms. We role play conversations. We walk through, okay, what does it look like to be collaborating with your care provider? What does that look like as opposed to being more passive? And so that's a really important part of the work that I do with women.
Yeah, phenomenal. Tamara, I like to shift gears a little bit and ask you about your practice. Is that okay?
Absolutely.
So how do you know that a client is a good fit for you and that you're a good fit for your client?
Well, I'm a little old school. I know a lot of people don't like to do this anymore, but I still do the free 15-minute consultation. And quite frankly, that's for me. That's not for the client. So how do I know? I look for things like motivation. I look for things like an openness to engage in treatment. Um, and I look for somebody who fits my area of expertise. So is this person in midlife, and kind of what is happening with them. I generally attract high functioning professional women in general. That seems to be the people that come to me. There's no intentionality around that, but that seems to be the type of people that come to me. So they are generally motivated. Some come with some information and some understanding that they're already in the transition. And then sometimes people come and they're just not really sure what's going on, and they're coming with complaints of, anxiety and worry and that
Got
kind of
it.
stuff. Yeah.
Got it. Yeah. Yeah. Thanks for sharing that. So let's say a client reaches out, they do the consultation call, they seem to be a good fit, and then they show up to their first session. What does the first session look like with you?
Well, the first session is it is an assessment, and again, maybe I'm old school in that way. I'm still doing assessments, but I do have a menopause assessment that I do, and I may also ask you to do some measures, and there's some menopause screening measures initially, and then that's our first session, and then in our second session we set our goals together. And after I have a chance to kind of understand what your circumstances are, then we come back and we talk about goals, and we talk about how we're going to sort of approach those goals, and then we get going and we go, and I follow the client's lead, and sometimes that's direct and sometimes it's more circuitous, and sometimes people are with me for 12 weeks, and sometimes people are with me for years. So it depends on the individual, but yeah, I think I answered your question.
Yeah. Yeah. Thank you for that. Um, what does progress look like for a client that partners with you, Tamara?
So exciting when I get to see the progress. I love that. I'll tell you what it looks like. I have such a good example because I logged onto a session yesterday, and the first thing the client said to me is, "You're going to be so proud of me." And it was not about me that felt so good. It was that she had been able to step into something that had been so challenging for her, and something that we had worked on for quite a while. It was actually part of her presenting complaint. And she just, was able to really um, do something that really was a great example of her personal growth and how she has really stepped into her own. And that is such a big part of this process. This goes back to the identity stuff of really feeling, um, having a greater sense of being self-possessed, of being certain. And certain, we talk about this in my sessions, certainty does not look like what the outcome is. Certainty looks like that you're going to be able to handle it. And so when I see that and those kinds of changes in women who come in with uncertainty and come in feeling like they don't even know who they are anymore because of a lot of the symptoms that they're experiencing, to then stepping into these positions of um, certainty and self-assuredness is a lot of what I see when how I would sort of define the growth that I see
Yeah,
my
that's really
clients.
cool. Yeah, and thank you for
Yeah,
sharing
it's
that
cool.
story about your client. Congratulations too. I know as a clinician that
Cool.
those moments are just those eureka moments are amazing, and especially because we're given the privilege of entering the client's like innermost world, their intimate world. And when we see that growth, when we see those moments of victory, like it's just so exciting. And so congrats to you, Tamara. Um, I wanted to ask about kind of like the end of therapy with you. How do you know when it's time for a client to like graduate or terminate therapy?
I always tell people that this is a decision we're going to make together. It's not a decision that I make, and I, hope to partner with them in that decision making. It seems to sort of unfold naturally. They will, it's, it seems natural to me. We also, of course, if we're meeting goals and we don't, and we're struggling to set new goals, that is also an indicator that, you know, maybe we've done what we've needed to do here, and you are ready to, you know, not be in therapy anymore. And therapy, I always say, is a kind of thing that you come and go, and you may come to me for a period of time and we work together, and then you are not in therapy. You may come back to me, you might go to somebody else. That, all of that is okay, because it's all a process. So I find that therapy ends mostly organically, because we have met goals and we're not identifying new goals that we need to work on, or it's just you slowly see that the client is no longer, you know, really needs the support anymore.
Yeah, yeah, that's awesome. Tamara, what's been the feedback from the clients that you work with about the work they've done with you?
Yeah, they're really, really appreciative and you know, grateful. And you know, I've had people who have said to me that the information they got from me was more than they could get from, you know, their doctors, and that you know, it makes me sad to say that. I'm glad that I can be a source of information, but it pains me to know that women are still going through what I went through, or, you know, some other kind of struggle to get the care and the information that they need. So
Feedback's
there's
been
that.
good. Yeah, that's
Yeah.
awesome. Tamara, yeah, thanks for sharing that. I'd like to shift gears and ask about your practice. So what's on the horizon for you? Are you maybe hiring some staff? Are you enrolling maybe a coaching program or an online course? What's kind of in the future?
Well, in the future, I'm working on a 4-day course, email course right now, and it's free. And I'm calling it Thriving Through Menopause. And the way to get to be able to have access to it is to go on my website and opt in to my free toolkit. There's a toolkit that I also have, where there are symptom trackers, and there's a meditation, and there's information about having conversations with your doctors. There's all kinds of resources there. And once you opt in for that, then you will automatically be on my list for the 4-day um, Thriving Through Menopause email course that is coming soon. I'm also very close to starting some groups. I have an 8-week support slash psychoeducation group. It will be a closed group, so it'll start and stop with the same people. And if you're on my list, you will get information about when those that groups are going to start. But I have enough people now that want the groups, so it's going to be starting soon. And I'll probably have concurrent groups.
Oh, that's awesome. Tamara, is that open to clinicians, or is it only for like the general public, non-clinician? What does that look like?
It's not focused on clinicians. I am doing some additional clinician work. I am not there yet, but I am working on some things for clinicians. So stay tuned. I will be sure to update you when that's available.
Yeah, awesome. Yeah, more to follow
Yeah.
on the courses for clinicians. Really excited about that, Tamara. Yeah, really, really awesome. Tamara, so I wanted to ask about um uh connecting with you. If somebody likes what they're hearing, they enjoy your style, everything you had to say, and they want to partner with you, how can they reach out to you?
Yep. So my website is thenewchange.org. You can contact me there. You can contact, I think my office phone number should be there. There's a contact form there. I am open to speaking with providers who want more information. If you have a case and you're not sure what's going on, you can certainly reach out to me. Or if you want more information about anything that I've talked about, I am open to it, because I feel the need to support clinicians who want this information. So I'm available. I'm not selling anything. I'm not trying to, you know, I'm just making myself available to you. So if you're a clinician and you want more information, you can reach me through my website, and I'd be happy to talk with you or email with you.
Yeah, and in a world where a lot of things live behind paid wall, the fact that you're making yourself available to clinicians for free just to provide support, man, I think it's just really a testament to you and the quality of services that you provide, Tamara. So thank you for offering that to our listeners. That's really awesome.
Yeah, for sure. People
Well,
reach out and they want info, so I'm available.
yeah,
Yeah.
yeah, that's great. Well, Tamara, thank you so much for your time today. This was a great, informative session for me personally, and I'm sure my viewers got a lot out of it. So thank you so much for coming on the show today.
Yeah, thank you for having me. This was fun.
Yeah,
Thank
maybe we
you.
could maybe we could do it again in the future. How does that sound?
I would love to,
Yeah,
with
super.
updates. Come
Yeah,
back.
yeah, that'd be great. All
Yeah.
right, everybody, thanks for tuning in on this one. Till the next one, signing out. Bye.